copy. I will paste it into my
Mhm.
YouTube. And then you can just let me know how it works. So it'll be kind of similar where you do the introduction and you let me know. Oh, okay. So I
Mhm.
can
I
see it.
think we're on live.
Okay.
Yeah. Okay. Good morning, everyone. Thank you for joining us today in our eShadowing session. It is a great pleasure to introduce all of you to our physician, Dr. Swenson. She's a doctor specializing in physical medicine and rehabilitation, and we will be sharing her journey to medicine and her specialty. As a reminder, towards the end of the session, a Google link will be posted in the chat so you can take the assessment and pass with a minimum of 70% to receive your hour for the session. And with that being said, Dr. Swenson, whenever you're ready, feel free to take the
All
spot.
right. Good morning, everyone. And thank you for having me. And thanks for that introduction. I am learning all about this YouTube Live this morning, so I'm really excited to be here. And I'm excited to share with you guys a little bit about my journey and my specialty as well. I'm a second year physician in physiatry, which is a smaller specialty in medicine, and it is also known as physical medicine and rehabilitation. And you might see it abbreviated as PM&R. So I'm going to tell you a little bit about my journey. Let's see. And I'll also try to look into the YouTube Live for some questions if any come up as well too. But if any come up and I don't hear them, you know, feel free to interrupt me as well too. But this is a brief introduction of my outline of my talk. I'm going to be talking a little bit about where I came from and how I got to the career that I did get to. I find that through my Instagram, which is how I end up connecting with a lot of pre-health and pre-medical students and medical students as well too. They often like to hear kind of my journey, so I like to share that. We'll talk then about physiatry, and we'll go over a few case studies. And these are meant to give you all an idea for the conditions that we see as physiatrists or PM&R doctors and the things that we do. We'll then talk about training to become a physiatrist and why I think you should think about becoming one, and why I became one myself. And then I'll just end up with some advice that I always like to give to students based off of the things that I have learned during my career thus far. Let's see. So a little bit about me. I heard that a lot of our students are from California, and I was born myself in Los Angeles, California. Both my parents are Vietnamese, and when I was 3, we moved to Denver, Colorado, and I spent most of my life there until I left for college. I went back to college out in California at Stanford University. And when I was there, I spent a lot of time trying to figure out what I wanted to do with my life. I didn't follow the traditional pre-med route. I neither of my parents were doctors, and I didn't really consider it until actually towards the end of college. So I actually ended up majoring in this major called product design. It's a subset of biomechanical or mechanical engineering. And it was really one of the things that I was excited about because a lot of product design is based off of working in teams and studying design theory. We also worked with a lot of companies in the industry, and we carried a lot of ideas from concept to working prototypes. So I really loved my major. I wasn't sure what I wanted to do with these skills though. And I ended up working for a health startup company called Doximity. So some of you guys might know Doximity as like the LinkedIn for doctors. But I worked with them for a little bit. I did some research projects at Stanford, and then I actually stumbled upon some physiatrists while I was at Stanford before I thought about going to medical school. And they kind of took me under their wing. They were teaching this class. It was a musculoskeletal and lifestyle medicine class. And I started doing some research with them after taking their class, and I got to know them a little bit more. And so then I became interested in medicine and specifically in becoming a physiatrist. So 2 years later, I ended up going to medical school at the University of Colorado. I'm currently a resident, a second year at Vanderbilt University in physiatry. And you might think that it sounds like before I even went to medical school, I kind of knew I wanted to be a physiatrist. So if that's what you're thinking, you might be right. So today, I'm hoping to tell you all a little bit about physiatry so that just like my mentors at Stanford, I might be able to inspire some of you and some of the people who listen to become physiatrists. Right. So physiatry, the word actually comes from two Greek words, physikos, which means physical, and atresia, which is the art of healing. And physiatry, or physical medicine and rehabilitation, or PM&R, is a broad field, and we specialize in a philosophy as opposed to an organ system. So that's something that makes us very unique, as opposed to other specialties which focus on organ systems like the heart or lungs or kidneys, or the diseases that correspond to those systems. We really focus on prevention, restoring function, independence, and maximizing quality of life. And that's the quality of life that has been lost through injury or illness, or other conditions. And I really like to think that any patient, really, any person can benefit from a physiatrist. Um, and I'll go into a little bit more detail later about kind of the teams that we work in. It's a very interdisciplinary field. But one of the things about physiatry is that it's a newer subspecialty in medicine. Our field actually really began to develop during World War II, during World War I, actually, and through World War II and the polio epidemic. So during these periods, there was an increasing need to take care of injured vets who were returning from combat, as well as patients who were living with chronic disabilities and weaknesses after suffering from polio. And so that's kind of where our field was born. And in 1947, we were recognized as a medical specialty. So we treat a broad range of conditions, and we also work with diverse patient populations. And like I mentioned earlier, I like to think that any patient really can benefit from a physiatrist, and that includes everyone from tetraplegics, stroke patients, patients who have been in the hospital for months and months, and even people on the other end of the spectrum, such as Olympic athletes. So some of the conditions that we treat include the neurologic system. So that includes things like patients who have suffered from brain injuries, spinal cord injuries, stroke, multiple sclerosis, and Parkinson's. Within the MSK system, we treat patients with amputations, osteoporosis, arthritis. We work with a lot of patients with work and auto-related injuries as well too. And the symptom that we treat is pain. Pain can come from joints, bones, muscles, ligaments, tendons, bursa, or back pain. It's kind of what we focus on. And then we also oversee these rehabilitation programs, for example, for patients with primary cardiac and pulmonary problems. So some of these patients are post-transplant. They recently had a big open heart surgery. They might have end-stage COPD and other things that have made them very, very deconditioned. And we take care of them and help them get stronger so that they can go back to living their lives after they've been acutely hospitalized, for example. Some of the diagnostic tests that are within the scope of practice for physiatrists include X-rays, MRIs, and CT scans. Ultrasound is a very important skill that we learn too. So for those of you who are interested in ultrasound or who have seen like one of these like handheld ultrasounds in that right corner, we use those to look specifically at muscles, joint tendons, and look for pathology. We also conduct nerve conduction studies, or NCS, and EMGs. That's another relatively unique skill to our training. Nerve conduction studies, those evaluate the function of motor and sensory nerves. And so that helps us to distinguish the location of a nervous system lesion. And EMGs, which are electromyograms, help us distinguish whether weakness is due to muscle, which is a myopathy, or nerve, which is a neuropathy, whether those are due to muscle or nerve dysfunction. And to do these, we insert needles. I don't know if any of you have ever seen an EMG or needle conduction study, but we insert thin needles into the skin, and then we detect the electrical potential generated by the muscle cells, and that helps us to elicit pathology. So I have this brief video that I was going to show you all just to give you an idea for what nerve conduction studies are actually like. So if it'll download, we'll go ahead and play it, and then we're gonna fast forward. Let's see. Here.
Based on your symptoms. So the length of the test is different for every patient. Usually it takes between 30 to 60 minutes. First, the technologist or doctor may warm your body by wrapping you in a blanket or soaking your hands in water. Warming your body helps them conduct the best study possible. Then there are two parts to the study. First, the nerve conduction study uses small electrical shocks to study your nerves. You need to relax your muscles during this portion of the test. Some patients report that this feels like a series of carpet shocks. Next, the needle EMG uses a small needle to evaluate your muscles. The doctor may ask you to move a certain way while the needle is in the muscle. You may feel some discomfort during this portion of the exam.
Right. So hopefully you could all hear that, and hopefully that gives you a little bit of an idea for some of the things that.
Some patients report that this feels like a series of carpet shocks. Next, the needle EMG uses a small needle to evaluate your muscles. The doctor may ask you to move a certain way while the needle is in the muscle. You may feel some discomfort during this portion.
Is that better? I think that was playing in the background. All right, we back online? Let's see. There's that, and there's that. All right, we'll stop this. Okay. All right. And you all can hear me okay as well too?
Body's great right now, yeah.
Perfect. All right, you never know with some of these videos that they'll go through, but hopefully you could all hear that and see that. But moving on, some of the treatments that we offer as physiatrists. So we are not surgeons. We do not perform surgery. Rather, we treat conditions non-operatively, and that can come in the form of several different modalities. One is injections. So we do peripheral joint injections to diagnose and treat disorders under ultrasound. We can also do trigger point injections, which is more of an adjunct treatment. And certain specialties within PM&R, such as interventional spine, they actually use fluoroscopy to provide non-surgical pain relief for back pain. And so they do fluoroscopic guided injections. We also manage spasticity. So spasticity is, you can think of that as like muscles that are like tight or rigid. And we do that by doing Botox injections. And we prescribe oral medications and manage baclofen pumps as well too. We also oversee rehabilitation programs. So I had briefly mentioned earlier that we work in interdisciplinary teams, and other members of our team include physical therapists or the PTs, occupational therapists or OTs, and speech language pathologists, which are the SLPs. So briefly, physical therapists, they help patients improve movement. Occupational therapists work with patients to help improve skills that they need for daily living and working, such as getting dressed and using a pencil, so kind of the fine motor skills. And speech language pathologists are experts in communication and swallowing disorders. So they help patients improve their language and social communication. So as physiatrists, we are really the leaders of these teams. We kind of oversee and manage and coordinate all these different specialists. So just like any other physician might prescribe a medication, we prescribe the physical therapy. We also work closely with patients to provide them with adaptive devices as needed. So that can be in the form of prosthetics, which are artificially made limbs that replace a part of the body that's missing, or orthotics, which are devices that are used to correct or enhance the function of a body part. So two different things, but both adaptive devices. And we also perform other procedures like acupuncture and PRP injections, which are relatively new. And I personally don't have as much experience in those things, but that's also a part of the training that we end up getting. Okay, so now we're going to go over 2 case studies, and I hope that these give you an idea for what it is like to work as a physiatrist and the breadth of patients that we see. We're going to go over an inpatient study, so one that you would see if you were working on the inpatient rehab unit, and another one is an outpatient clinic patient. So this is a patient who came to us not too long ago, and it's very relevant now, obviously, with the COVID-19 pandemic happening, but we had a patient who was a 49-year-old male. The only real medical history he had was leukemia, and he came to us in IPR or inpatient rehab, IPR, for deconditioning after he was hospitalized for COVID-19. And to give you a little bit more of a background on him, he was relatively stable, but he was diagnosed with chronic myeloid leukemia with blast crisis, and eventual conversion to acute leukemia earlier this year. And he underwent 5 cycles of chemotherapy. He was otherwise doing fine after that, and he was working in his yard, mowing the lawn. He had like 5 acres of lawn until September 2020. And at that time, he was brought to the ED because he had per his per his wife, 1 week of generalized weakness and confusion. He was very confused and he couldn't give us a clear history, but his wife was able to tell us that he was slow to respond to questions. He wasn't making sense, and he was doing a lot of nonsensical things like putting towels in the toilet. So he came to the hospital because of this acute encephalopathy or confusion, altered mental status. He underwent a very extensive infectious and cancer workup. So things like a chest x-ray, urinalysis, imaging of his head, to see if there was another cause for his confusion. And all of that was negative. And the only thing that was positive was his COVID PCR. So he was seen by multiple different specialists, like oncology, hematology, psychiatry. They really felt that his altered mental status, though, was unrelated to leukemia or any other etiologies, and that this was actually a neuropsychological sequelae of COVID-19. So after all of this, he was sent to us in the inpatient rehabilitation unit. And I want to mention that before we even see him, there's a lot that happened to him. So he was, as I'd mentioned, seen by all these specialists. He was in the hospital. And even though all this happened before we really get to see him, it's important for us to be able to understand his medical course, because that sheds light on his recovery. And it's important to be able to manage all these things while he is with us on inpatient rehabilitation. And briefly, also the complications that he might have had in the hospital, that gives us an idea for how deconditioned he is, and how much therapy he might need. So back to seeing him now on inpatient rehabilitation. Some of the reasons he's coming to us are the following listed here. So he had decreased strength. He had dependence with his ADLs and IADLs, as well as cognitive impairment. So ADLs, those are activities of daily living. That's what the A, D, and L stand for. Those include things like eating, bathing, getting dressed, toileting, mobility, like walking around. IADLs, those stand for instrumental activities of daily living. And those, we like to think of them as requiring slightly more complex skills like cooking, driving, caring for pets, using a phone or a computer, keeping track of medications. And both of those things, IADLs and ADLs, are important, as evident in their name, for daily living. And then finally, cognitive impairment, that describes an impairment in his ability to think, plan, remember new things, and make decisions in his everyday life. So once we understand all these things, what do we actually finally do? So he arrives on our floor. We go and meet him and his wife. We've already read his charts and understand everything that happened before he got to the hospital. So our job is to really understand what his life was like before he came to the hospital. So we really care as physiatrists about his social history. A basic social history includes things like how much he smokes, drinks alcohol, uses drugs. But there are other aspects of social history that are important to physiatry. For example, his level of education, that affects what his cognitive baseline actually is. So that's important for us to know. His employment. So does he work at a job? Is he currently working? Is he planning to go back to work? Is he at a job that requires him to be up and walking around, or to use like his hands and his intricate hand muscles? Might he need an assistive device or accommodations at work? We also like to dig into their hobbies and how active these patients are, because our goal is to get them back to being able to do all these things and living their lives. So we want to know what their life was like before, so we can get them back to doing it. We also want to understand his living environment. So how many steps he has at home, because it'll be important for him to be able to navigate his home. Otherwise, he might have a fall. If he lives in an elevator or an apartment building, does he have a shower with railings? Because that's another opportunity for him to fall, or a hazard, I should say, if he isn't able to navigate his way in the shower. And that helps us think about things like whether he needs assistance like home health services or someone additional at home. We also want to understand his current and prior functional status. So is his wife expecting him to go back to what he was doing previously? I mean, he's 49 years old. Sometimes we have like 80 or 90-year-old patients come in, and their expectations are going to be different than 49-year-olds. But for him, is he expecting to go back to working full time, and walking? And how far is he walking? Can he get out of bed right now? So those are all kind of the things that we care about. And for our patient, just relevant for him is that I think I briefly mentioned this earlier too, he works on a 7-acre farm. He's very active on his feet. He was driving a tractor around, very functioning, independent prior to his hospitalization. He lived with his wife and 2 children, who all depended on him. And, cognitively, he was thinking perfectly fine. He was managing all the finances. He was doing everything on his own and for his family before he came to the hospital. So then we examine him. So specifically, I like to think that as physiatrists, we focus really on the neuromuscular exam, so neuromuscular. In addition to listening to his heart and lungs, of course, that's kind of the on every patient, we should also listen to their heart and lungs, but we really focus on strength and musculoskeletal exam. There's certain other specialized neurologic exams and cognitive evaluations that we can do, depending on the type of injury that patients have. But I think that for our purposes here, it's really just neurologic and MSK exam. So for him, he had some weakness in his lower extremities. We tend to rate to scale. We don't tend to actually rate our strength on a scale of 1 to 5, with 5 being the strongest. So in his strength exam, he was about a 4. He had been walking around the hospital, but he was requiring the use of a rolling walker, so an assistive device. So he'll need some physical therapy to improve his strength, hopefully get him to independence and not be reliant on a rolling walker to walk. And the thing that really brought him to us was his cognition. So cognitively, he was very far from baseline. We say that he needed maximal cueing for simple commands. He had difficulty initiating tasks, was very fidgety and distractible. So he'll need to be seen by speech language pathology as well as neuropsychology to work with him to develop routines and practice problem solving skills so that we can get him back as close as possible to his baseline. So our job in the hospital, while these patients are with us, while a patient like him is with us, is to oversee the physical therapy as well as the speech language pathology, SLP therapy that he is getting, and monitor his improvement over time and determine when it would be safe for him to go home. If anything medical comes up, like he becomes agitated, confused, he has pain from working with therapy, he might develop a UTI or other things that can be treated outpatient. We work those up as well too. We order, all the tests, imaging that hospitalists or internal medicine doctors would order. So I like to think of us as the primary care doctors in the inpatient rehabilitation setting. The last thing I want to emphasize is that, about this case at least, is that rehabilitation is an ongoing process. So we work with him, we get him walking around the unit independently. Cognitively, though, for him, his rehabilitation process is ongoing. He's still recovering from COVID-19, and the trajectory is different for different types of patients. So while he's with us in intensive inpatient rehabilitation, we see him for that amount of time. We often continue to see these patients as outpatients in our clinics, and they continue to get outpatient therapy as well too. So we get a lot of continuity of care, which is fun as well too. So I can pause here. I haven't looked at the YouTube video yet, but if you want to interrupt me, if there's any questions or anything that is being asked, we can do that too. Otherwise, I have our second case study to go through.
I think you can just keep going on. We can do the questions at the end.
That sounds perfect. If you want to feed them questions to me too, feel free to interrupt too. But
okay, gotcha.
So our second case study. So my particular interest as well too is in sports medicine and musculoskeletal medicine. I think as physiatrists, people tend to either fall along the spectrum of wanting to do more than neurology or the musculoskeletal medicine. So I see a lot more musculoskeletal medicine in the outpatient rehabilitation setting. So we're going to talk through one of those cases as well too. And specifically, we'll be talking about a patient who is a 19-year-old coming in with knee pain. She's a 19-year-old runner with knee pain. And as physiatrists, here in this specific case, anatomy is very important to us. So I'll just briefly, to kind of get us all on the same page, just talk briefly about knee anatomy. The knee is this modified hinge joint. It's the largest joint in the body, susceptible to injury because it rests at this long lever arm of the tibia and femur. And it's the knee is the spot where the femur and the tibia join up and articulate. So that's the tibiofemoral joint, aka the knee. And there's a bunch of muscles that sit on the knee. that sit on top of the bones, like the knee extensors, flexors, your rotators, the popliteus, which unlocks the knee. And then there's a bunch of ligaments as well too, like the ACL, PCL, MCL, and LCL. But since this is more meant to be an overview and not meant to be an anatomy lecture, kind of gives you just a broad overview of the knee anatomy. So especially since I'm still a resident, I often like to review knee anatomy even before I go in and see a patient and jump into the case. So now that we've done that, we'll go ahead and jump into the case and get a little bit more history from our patient. So when we take a history on a patient, especially one that comes in with pain, I like to use this mnemonic, OPQRST, onset, provocation, palliation, quality, radiation, or region, severity, and timing. So that helps me make sure that I get a full history on the patient and I don't miss some important things that I otherwise wouldn't think to ask. So for our patient knee pain or onset that began several months ago, it is provoked or worse with walking down the stairs and running down hills. She has stiffness after sitting for a long time. So that's another thing that provokes her pain. Other things that are associated with it, she hears a popping sound in her knee after prolonged sitting. The location or the region of the pain is at the anterior or the front of the knee. In terms of severity, she rates it on a scale of 1 to 10 as a 5 in severity. And timing, so we talked a little bit about that. That's when she runs is it started. Well, I guess it started several months ago too, but that gives you an idea for timing. Physical exam. We then do a physical exam and take a look at the knee. We assess for areas of tenderness. We look and see if there's swelling, not too much swelling on her, and we assess her range of motion. The thing that I think is really fun about musculoskeletal exam is that there's a bunch of tests that you can do, like the drawer test, the McMurray test, bounce home test. There's a lot of tests that you can do. And depending on which test you do, you can come up with a theory for what actually is going on. But we get a lot of information from our physical exam, and that can help us guide us as to whether we need further imaging. And our patient will go ahead and order an x-ray to look for like a fracture or bony abnormalities. But specifically for her, it helps us visualize the location of the patella on the femur, and also detect if she she's 19 years old, but it could help us detect if she has any early arthritis as well too. So after all this workup, we end up diagnosing her with patellofemoral pain syndrome, aka runner's knee. So very it's in the name, PFPS. It's anterior knee pain that is caused by improper tracking of the patella along the distal femur. So you see in this image that there's the patella, it's against the femur. If it doesn't track properly along this path, that can cause pain. And so by taking x-rays at different angles, we're able to see when her kneecap goes off track. But ultimately, based off of our history and our exam alone, our suspicion for PFPS is high because in a runner with knee pain that is worse going downhill, that sounds very much like PFPS, which is a very common complaint, especially in young women runners. And it results from a combination of structural factors, muscular imbalance, and quadriceps weakness. So after that, we focus on treatment. And this is from RN non-operative treatment. A lot of those things will involve activity modification, correcting incorrect running form or mechanics that may be contributing to the pain. Rest and ice, as well as NSAIDs, are really the foundation for any musculoskeletal complaint. And then we refer her to physical therapy. So we'll ask the physical therapist it's important for her to strengthen her quadriceps and stretch the hamstrings and adductor muscles as well too. And we could let them know that they could consider knee bracing or a patellar knee sleeve with a patellar cutout that can prevent re-injury and allow the patient to slowly resume activity. So we try all these things. Consult to orthopedic surgery as a last resort, but there's a lot that we can do before that happens. So now that we've talked through a little bit about those cases, I want to tell you all a little bit about what it takes to become a physiatrist. I think it's important just to consider and to know kind of what you're signing up for. So physiatry is, we do the 4 years of undergraduate, 4 years of medical school, 1 year of internship. So since physiatry is a specialty, it's an advanced position. every physiatrist is required to do a 1-year internship, which is usually in internal medicine, surgery, or transitional year. Internal medicine, a foundation in internal medicine, especially for inpatient PM&R, is very, very helpful because we manage a lot of those primary care-based complaints as well in the inpatient rehabilitation setting. Physiatry residency is then 3 years, and you can do it's actually a 1 or 2 year fellowship if you'd like. There's over 80 accredited PM&R residency programs in the US. Fellowships are optional. And again, that should be 1 to 2 years of fellowship on the slide, but a little under half of physiatrists, I believe like 43% or so, actually complete a fellowship. Because theoretically, as a physiatrist, you should be able to do a lot of the things that you're already trained to do, but some people want that extra training. So residency, residency isn't forever, but I still think it's important to think about. In general, residency classes tend to be pretty small. So whereas my internal medicine intern year residency class was like 80 to 100 people, PM&R programs, 80 to 100 people per year. PM&R class sizes tend to be smaller, so like 2 to 14 residents per class. In my class, there's a total of 4 of us per year. So definitely always pros and cons to small class sizes, but you get to know your residents very well. In addition to completion, in order to complete residency, you have 12 months of required inpatient, 12 months of required outpatient, and 6 months maximum for research. So here are some of the things that you might see on inpatient rotations. So you might be seeing patients who just have general deconditioning, and you'll see them on inpatient rehabilitation. Patients with neurologic disorders, strokes, brain injuries, spinal cord injuries are some of the rotations you might be doing. As far as outpatient rotations, you have required 12 months of outpatient. There's a handful, some of which are required depending on the programs that you go to, but some of these include amputee clinics, EMGs, spine, and sports medicine. Those are some of the popular electives. And after that, you have 12 months, depending on your program, that are a combination of inpatient and outpatient months. You have 6 months maximum for research. So if you are someone who is more interested in pursuing like what we call like a rehab medicine scientist training program, or RMSTP, or you want to become a researcher and get NIH or other research funds, there's options to do that. Other things that people just like to ask about just to know, call. We all take call as residents. So we're responsible for in-house versus out-house call. It depends on the program, whether you're in-house, like sleeping in the actual hospital, or at home. And it ranges from every 4th night to every 11th week. And for us, I take 8 weekend calls per year and 26 weekday calls. And so there's opportunity in physiatry, even as a resident, to become involved in other extracurricular things. Like I'm able to spend time talking to you all today because I'm not on call this weekend. And I think that's one thing that I love about being able to be here in residency, doing some of the things that I like doing before I even become an attending. So I feel very fortunate. There's opportunities for extracurricular involvements as well too. So whether that's recruitment for PM&R, doing research, mentorship, something that I do that I think is unique, and I don't think I would be able to do it in any other residency, is working with the Entrepreneurship and Design Center at Vanderbilt. So because I have a background in product design, I have a very big interest in healthcare technology and entrepreneurship. So I've gotten involved with working with some of them. It's been fun working with these startups founded by PhDs and MBAs, and like kind of that interdisciplinary work that I get to do. And also work a little bit with Doximity as well too, still just writing for them and doing things on the side. So it's a lot of fun, able to build your career even as a resident. Here's another thing to look into. It's kind of the subspecialties and fellowship options that you guys might have if you think about physiatry, if you want to do that extra training. And I broke it down into ACGME accredited and non-ACGME accredited specialties. So ACGME, it's an accreditation council for graduate medical education, and they set standards and provide assurance that certain programs meet quality standards. So there's like, I guess, kind of like official and unofficial, like accreditation committees. So some of these ACGME fellowships include hospice or palliative care. That's a big component of what we do in inpatient rehab as well. Neuromuscular medicine, pain medicine, if you like pediatrics, you can do that as well too. Spinal cord injury, sports medicine, which is what I'm interested in, traumatic brain injury too. There's other non-accredited specialties or fellowships such as cancer rehabilitation, multiple sclerosis, neurorehabilitation. I'm really excited to see more and more of what physiatry does pick up, because certain things like certain components of physiatry are just beginning to be developed now. So there's something called pelvic floor rehabilitation that I've had prior upper level residents pursue, and it's kind of like pelvic floor, working with OB gynecologists to work with women who are postpartum and to do work with their physical therapy team and help them recover after being pregnant as well too. So there's lots of ways that you can, and lots of opportunity for creativity too, to pursue, I guess, fields of physiatry that haven't been yet explored. Life after training. So depending on if you decide to pursue a fellowship, you can work in a variety of different environments. That includes inpatient and outpatient settings, as well as consulting roles. We practice in academic settings, as well as group practices and solo practices. You might see us in a sports medicine clinic. So that's where I saw my first physiatrist, and that's where I hope to be someday as well too. But you might also see us in neurology clinics. You could see us in the acute care hospital, in a rehabilitation hospital, in a skilled nursing facility, and other places. As mentioned earlier, PM&R is a team sport. So you might see us working with other members of our team that include neurologists and orthopedic surgeons. Those are teams that we work very closely with, as well as neurosurgeons and trauma teams too. We lead a team of healthcare providers that include the physical therapists, occupational therapists, speech language pathologists, and respiratory therapists, as well as nurses too. So we work very closely with them, and I always try to talk to my therapists and my nurses too, to keep them in the loop, especially on inpatient rehabilitation. So there are many reasons to choose a career as a physiatrist, only some of which I've listed here. I think physiatry is incredibly meaningful, and it leads to a very meaningful career. So whereas patients often don't want to be in the hospital or to see most doctors, many of our patients, not all, but many, are excited to see us because they want to get better. I love working with patients who are young or old. I'm on the traumatic brain injury service right now, and I love my patients who I see them recover, I see them do better, I see them get back to living their new lives after they're adapting to their new disabilities, and it's really fun and rewarding. Because I see them in the inpatient side, and then they see my attending, but they sometimes we see them too in outpatient clinics after they've been on the inpatient side, and we see them walking around and just completely different people from how they came to us. Our patients are very motivated, so they want to get better. They're also pretty diverse. You can really choose the type of patient that you want to work with. So briefly touched on already, but you can choose to do pediatric rehabilitation, paraplegics, you can do women's health and pelvic floor rehabilitation. If you wanted to work with Olympic athletes, you could do that as well too. Physiatry is a multidisciplinary field. So if you like neurology and musculoskeletal medicine especially, you can do both as a physiatrist. You also work in a team with other physicians, and we already talked a lot about that, but I really like working in a team because I think that medicine is a team sport, and it's a lot more fun when you have other people working with you. Lastly, physiatry is full of opportunities. So I think that I think physiatry is a newer and relatively lesser known specialty. You all can tell me if you've heard of physiatry or know about it before, but more and more medical students are starting to get to know about us. And so it's becoming more competitive each year, and we've actually gone unmatched for the past few years. So every residency spot has gotten filled previously. And that's not the case for most specialties. I think the other ones that we share that title with are like orthopedic surgery and dermatology, and maybe like neurosurgery too, but it's getting more competitive each year, and it gives you the opportunity to have significant activities, work-life balance, extracurriculars outside of medicine or within medicine. And I think that that's just important to think about, especially if you're thinking, depending on your interests as well too, if you want to make time to pursue other things like working with tech companies or writing. For example, one of my co-residents is a writer, so she has time to do that. So lastly, I always like to give students 3 pieces of advice. Not that you need any more advice, but I just like to give it. My first piece of advice is to pace yourself. So everyone says that medicine is a marathon, not a sprint. And it really is. I think that for the longest time, I always looked really far into the future. And I thought, once I get into, even starting in high school, once I get into a great college, I can stop worrying and I can finally start seeing my friends and enjoy life. And then I went to college and I still didn't know what I wanted to do until I figured out that I wanted to go to medical school. And then I kept telling myself that I needed to go to medical school, and then I could finally, then everything would be okay and I would be settled. And I've realized, it never really ends. Now that I'm a resident and I have used that excuse on myself many times and waited for the board exams and studied really hard and waited for that, I guess did the sprint and realized it was a marathon. I realized that you really have to be happy with what you're doing in the moment, because life is pretty short, as we can see. But also, when you think about residency, it's not forever. When you think about medical school, it's not forever too, but you want to make sure that you're happy doing it and that you pick something that you could see yourself doing for a long time and that doesn't burn you out just through the training. And secondly, when you do a lot of these things, I think there's a sense of freedom when you're pacing yourself to be able to embrace opportunity, which is my second advice. So when I got to Stanford, Stanford's full of very smart people. I felt out of my league. Everyone was kind of doing all these things with venture capital companies, but they were also hanging out with me and tailgating with me on the weekends. And I kept searching for my passion because I saw everyone around me kind of figure out their passion. And I tried a lot of different things. And at a certain point, I was like, oh, well, maybe I shouldn't have majored in product design because, I felt like in medical school, I didn't have as strong of a biology or chemistry background. So I thought I struggled a little bit more in medical school than I otherwise would have. But had I not taken product design, had I not taken that lifestyle medicine class, had I not taken the opportunity to, talk to the physiatrists who were teaching that lifestyle medicine class, I probably wouldn't be doing what I am doing now. I probably wouldn't even be in medicine. So I think that, as you're trying to figure out what you want to do, I think that not being afraid to try other things and embrace opportunity is an advice that I would have given myself to embrace it more. I find that a lot of people who have been able to combine different disciplines and try different things have done very well in physiatry, and have also done well in medicine. So especially as you're trying new things. And I love being a pre-med and a medical student because I liked having all those opportunities. So don't be afraid to do that. And then the last thing, kind of cheesy, but I always think keep your friends and family close. When I was in medical school, I lived with my parents, and people always asked me how that was. And I thought it was great because they cooked for me, they helped me. Sometimes I would be running late for school and they would drop me off. And as a resident, I live very close to my in-laws now too. So I still have the same support system. I make time for my college friends. And especially as you get further and further in your training and your time becomes a lot more rare and scarce, I've just found a way to kind of defend that time and make time to stay close to the people I'm close with. So that's it. I have a few resources if you're interested in learning more about physiatry. A lot of these things that I've done, I found you all through Instagram, and I've been able to connect with a lot of medical students through Instagram. So if you all have any questions, you can feel free to shoot me a message on Instagram. I like to kind of show you all the things that I do both inside medicine and outside medicine as well too. So I've gotten a lot of questions about medicine, but also personal questions too. So I think that both of those things are very important to think about. So you can feel free to reach me there.
Thank you so much for a great presentation. I think we have one question in the YouTube chat right now.
Yeah. I'm impressed that people are up on a Saturday. Let's see. I don't actually see it. If you wouldn't mind reading it to me.
I can read it to you. So it
Yeah, that
says,
would be perfect. Yeah.
what's your favorite part of, I'm gonna say it wrong, physiatry? And what's your least favorite part about it?
Yeah, I think that's a great question. So my favorite part about physiatry, I think, is that I really like, and I'm someone clearly who tends to be a little bit more creative, and this is both what I like and what I don't like. But I like being able to kind of pick and choose what I want to do, since physiatry is pretty broad, but it's still a specialty. Um, and as someone who knows that I like neuromusculoskeletal medicine, I've been able to kind of pick and choose what I want to do. And since not a lot of people know about us, it's an opportunity to define who we are and what we do. I think that a lot of the physiatry, like I think if I scroll back, like the AAP and AAPM&R, they're really innovative and like exciting organizations that support physiatry. So I think that kind of where physiatry is headed, the amount of innovation. I think a lot of physiatrists are on Twitter too, which is kind of like the cool hip thing in medicine to do, I guess. But I love being able to do all the things that I get to do and call it a career, even as a physiatrist. I think the downside to that too, and this is both my favorite and least favorite part, is that again, not a lot of people know what we do. So if you know, as opposed to being a neurosurgeon, where if you say I'm a neurosurgeon or an orthopedic surgeon, everyone knows what that is. A lot of times, people wonder, you know, is physiatry? What is physiatry? Is that if it's like how's that different from physical therapy? How is that different from that's the big question, is how's that different from physical therapy? And that's not necessarily like physical therapists do a lot of amazing things, and they have their own specialties and their own contributions as well too, and their own training that's very different from ours. But it is hard, especially because I think that as a female too, to be able to say, no, I actually am the physician and I'm going to make decisions specifically about this patient's medical condition, that physiatrists aren't able to treat a patient's COPD, for example, or they don't prescribe medications for UTIs. And being able to kind of stand up there and be like the primary care physician, I think, is something that that since a lot of people don't know what we do, we kind of have to explain a little bit more. So both a pro and a con, I see it more of as a pro because I like being able to do all those things. And I also think that as you get further in your career and figure out what type of physiatrist you want to become, like ultimately for me, I hope I'll become a sports medicine doctor someday. I can really kind of define my niche within that area, and yeah, it'll be more of a pro. So.
Okay, another question. I'm just gonna kind of mix them together. Do you have any advice to overcome imposter syndrome, and any tips to keep yourself motivated during high school or like college?
Yeah, I love that question. And especially, I think, as a high school and in college, I will say that I've gotten a lot more confident and had less of that imposter syndrome as I've gotten further along in my training. I think it's something that affects different people differently, especially in high school and college, because you're still trying to figure out who you are, first of all, and then you're trying to figure out what you want to do. And you're looking around and you see all these people who are doing all these amazing things. And it's something that I really struggled with. I think that, one thing that I found is being able to talk to my friends. So for me, finding other, specifically women who are going through the same things that I'm going through and being able to relate to them has really helped me. Also finding mentors who understand. So whether that's someone who's, like for me, like a woman who's older than me, who's been through it and can show me the ropes, that's been huge. But there's also, a lot of my male colleagues, or my male, like my program director and chair are both men, and they really understand and they really get it. And just having people who can support you, I think, is the biggest thing. I do, I've certainly been there and I certainly know what it's like. So if you all have any further questions or need further support or advice, I'm happy to talk to you individually as well too. But I think mentorship and just knowing that you're not alone is a big thing. Yeah.
one last question. You mentioned that PM&R is a competitive residency to get in now. Do you have any advice on matching into the specialty now?
Yeah. So I guess we can talk about like medical students. I'm assuming from a medical student perspective. So it's getting more and more competitive, but the thing about PM&R is that we really look for fit. So we look for people who want to be in it for the right reasons. Ultimately, PM&R, you will work with patients with disabilities, and that can be really difficult. It can be hard to work and live with a chronic disability, and being able to empathize and understand those patients and what they're going through, that's a huge part of what will make you a great physiatrist. So I think that, yes, PM&R is getting more competitive. Board scores are important, but through all of this, like maintaining who you are as a person and maintaining your humanity and your love for medicine is what will make you a good physiatrist. And I think we really see that. So the other thing about physiatry is I think that there's people, from what I've seen, there's residents who've applied who on the very high spectrum of like step one scores, like 260s, but there's also like a lower range of step one scores too. And to think about all those things that, I guess, like kind of where does it, like, how do we all even out? And I think making sure that you're in it for the right reasons, making sure that you get involved early on, potentially with some of the research, reaching out to people, just knowing and hearing about physiatry is also helpful too. Doing a rotation in PM&R is helpful. Not every medical school at all has PM&R as a specialty in which medical students can rotate in. We're trying to change that. So and I work with AAP as well too, and I work with our program here at Vanderbilt, but we're hoping to get more access for students to have access to PM&R and see what it's like, because we all want you to make the right decisions and to really understand what PM&R is, because I think a lot of people don't. So some of those things should help.
Thank you so much, Dr. Swenson, for the informative and inspiring presentation. I'm sure we all learned a lot from this, and we're grateful that you took some time out of your day to speak to us.
Of course.
About your specialty, yeah.
Of course.
And all of those who are, thank you so much, yeah. Just for the people attending, if you wish to take this assessment, to get the hour for the session, we have posted the Google form in the chat, and you have 45 minutes to complete the form after the session. And that's it. That was it.
All right. Thank you all. And thank you, Pema, for having me.
Thank you so much. Yeah.
We'll see you later.
Thank you. And for our next session, we're going to have Dr. Toomer, who's a physician in family medicine. And again, if you wish to participate in our program, make sure you're using the same email throughout. And I hope you guys have the nice rest of the day.